Hello everyone, this is Dr. Humanist welcoming you all in the series of how to approach. Today's topic is how to approach a patient of proteinuria. Before understanding that, we will first see what is the normal composition of urinary protein. As you know, the urine protein is normally less than 150 milligram per day. In that, maximum composition, that is 70 milligram per day, is of TAM household proteins, also called as uromodulin, which is secreted by the tubules. Next is albumin. The albumin secretion is less than 30 milligram per day. Other proteins like from glomerulus, it is apoproteins, enzymes, beta-2, microglobulin, peptide hormones, etc. And from the tubules, urokinase and IgA antibodies. Okay, so proteinuria, you have to understand there are four types of proteinuria. One, glomerular proteinuria, then tubular proteinuria, overflow proteinuria, and orthostatic proteinuria. So to understand the glomerular proteinuria, we have to understand that there are three layers in the glomerulus. That the innermost is endothelium, which has pores of 100 nanometers, which allows all the proteins, large and the small proteins, but doesn't allow any blood cells, RBCs, WBCs, anything. So the next layer is glomerular basement membrane, which allows only the small proteins, including the albumin, but not the large proteins, which are more than 100 kilodalton. Albumin, as you know, it's 66.5 kilodalton. And food process, which has the slit diaphragm, it doesn't allow any protein, but allows water and solute, which is again reabsorbed by the further tubules. So depending on where the injury is, there is a selective proteinuria or non-selective proteinuria. As if the food processes affected, like in the minimal chain disease, which is the most common cause of nephrotic syndrome in children. So if food processes are gone, that means the small proteins, that is albumin, is lost, so which causes selective proteinuria. And on the other hand, when there is a glomerulonephritis, the entire endothelium is affected, so what happens is there is non-selective proteinuria. The next type is tubular proteinuria, in which the main protein is TAM household proteins. The proteinuria is less than 2 gram per day. The third type is overflow proteinuria, when there is exiting tubular reabsorption, then its capacity, so there is more protein loss. The causes are multiple myeloma, when, as you know, there is a loss of Benjamin proteins. So multiple myeloma, how does it affect? It causes injury to the proximal convoluted tubule. It causes cast nephropathy because of the blockage of the tubules. It also leads to amyloid deposition, light chain deposition, etc. The causes of overflow proteinuria are amyloidosis and lymphoma. And the fourth type is orthostatic proteinuria, in which there is usually minimum proteinuria, that is less than 1 gram per day. The pathophysiology of it is like when there is prolonged standing, it causes, as you know, decreased venous return to the heart, leading to decreased cardiac output and then decreased renal blood flow, which activates the RAS system. So as you know, angiotensin 2 is a potent vasoconstrictor or constrictor of the efferent arterioles. So now because of that, there is an increase in hydrostatic pressure in the glomerulus, and which leads to proteinuria, but which is less than 1 gram per day. So now coming to how to approach. So when a patient comes to you with proteinuria, which is detected by dipstick, urine dipstick, as you know, it's not specific. I mean, it only detects the albumin, but doesn't detects other proteins. Like in multiple myeloma, it won't detect the Benjamin proteins. So when you find there is a protein in the dipstick, what you do is you have to do albumin quantification. How you do? There are two methods. One is you have to do 24-hour urine excretion of protein and calculate it, and also, or you can do a spot early morning or first morning sample for albumin to creatinine ratio. So based on that, it can be either microalbuminuria, when the excretion is 30 to 300 milligram per day, or if the ratio like albumin to creatinine, 32 to 300 milligram per gram, that is creatinine. Okay, so both are equal. And if the microalbumin is there, the causes you have to consider are like early diabetes, or essential hypertension, early stages of glomerulonephritis, especially with RBCs and RBC cast that present. Now coming to the microalbuminuria, it is when the protein loss is between 300 to 3.5 gram per day. So in that, in addition to the causes which are included in the microalbuminuria, the additional causal multiple myeloma associated kidney disease, In this case, we had to do urine and serum electrophoresis. Other causes being intermittent proteinuria, postural proteinuria, in which the protein loss is less than 1 gram per day, congestive heart failure, fever, and exercise. Next is nephrotic range proteinuria, when the proteinuria is more than 3.5 gram per day. So in that, so the causes of nephrotic syndrome, as you know, the most common diabetes, then amyloidosis, minimal change disease, uh, focal segmental glomerulosclerosis, membranous glomerulopathy, IgA nephropathy. Thank you.